So thank you for the introduction. I am Sarah Danzo. I'm a clinical psychologist at Seattle Children's Hospital and University of Washington. Can you hear me okay? Can I make this louder? Okay, can you hear me now? Okay, I'll let him use the volume. I work in our outpatient MAP program, mood and anxiety disorders. I see a lot of youth with anxiety and depression, as well as families struggling with suicide risk. A lot of the kids we see in our outpatient crisis clinic come from the Seattle Children's Emergency Department, as well as primary care clinics and different community clinics. Our overall goal is to see youth in the least restrictive environment, which we'll talk about today to kind of reduce inpatient referrals. And as was already mentioned, I do not have any actual or potential commercial conflicts of interest to report, so we can just get started. So our learning objectives today are to review the current state of youth suicide. We'll talk about trends and numbers currently and across the last 2 decades, increase familiarity with this philosophy of least restrictive care. So this idea of kind of reducing inpatient admissions when possible and safe, and being able to treat youth in outpatient environments when it's appropriate. And then within that, describing the role of different healthcare settings and providers to reduce suicide risk. This includes both outpatient and inpatient specialty settings, but really focusing on healthcare settings without mental health specialties. And then identifying gaps in solutions for suicide prevention in different healthcare settings. And before jumping into this, I want to just start with some definitions. Most people have been familiar with the term suicide attempt. So this is any behavior that a person engages in with potential for harm and intent to die. Now within that, there's still different lethalities within a suicide attempt. And what we know is actually females are more likely to attempt suicide, but males are more likely to die by suicide. And the reason for this is differences in the methods used. The other thing I want to note is that the suicide attempt is not the same as death by suicide. Many people who attempt suicide do not die by suicide. They do go on to live. And that's another population we want to focus on with intervention. Under suicide attempts, we also have interrupted attempts as well as aborted attempts or self-interrupted attempts. An interrupted attempt is a person who engages in an activity with intent to harm their life, but somebody interrupts that attempt. And the really common portrayal of this in the media would be, the video you see where somebody is standing on the edge of a bridge ready to jump. A car drives by, somebody jumps out and stops them and pulls them back from the bridge. That's an interrupted attempt. That person planned to do something to end their life, but somebody interrupted them to stop them. An aborted attempt, or a self-interrupted attempt, is when a person takes steps to harm themselves to end their lives, but then stops. They interrupt themselves. And an example of this with youth might be a kid who's in the bathroom at home, they have a bottle of pills, they plan to overdose, and then they hear the front door of their house open, and that means somebody comes home. And they decide, well, somebody's home, I'm not going to do anything. So their action to stop is, determined a little bit by somebody else coming in, but they are stopping themselves. So this is a self-interrupted or aborted attempt. We also have non-suicidal self-injury up here. That's because non-suicidal self-injury is a major risk factor for suicide attempts. As the name implies, this is an injurious act without the intent to die. But as I mentioned, because it's such a big risk factor and it's so common in teenage and adolescence years, we want to really think about it as a major risk factor and warning sign and an indicator that we need to be screening and assessing for suicide risk. The last thing I have on here is suicidal ideation, and that's the most common one of these that occurs, especially during adolescence. This is any thoughts about killing yourself, thoughts about being better off dead, and it ranges from passive to active. So there's a really big range of suicidal ideation. Passive being something like wishing you were dead, wishing to go to sleep and not wake up, all the way up to active, thinking about how you want to die, planning how you want to die, thinking of methods and when you're going to do it. Suicidal ideation also ranges from fleeting thoughts that might just happen once or twice for a couple minutes, all the way up to persistent or chronic, where it can occur every day for several times throughout the day. And suicidal ideation is really the main thing that we want to be thinking about with screening and assessment to understand how high risk somebody is and what level of care is going to be most appropriate. All right, when we're thinking about this current state of suicide risk, I think it's been all over the news. It's not a surprise to anybody that right now we have a youth mental health crisis. Right now, suicide is a leading cause of death among 10 to 24-year-olds in the United States. It's the second to third leading cause of death in this age group. In 2021, it was the 11th leading cause of death across age groups. So to be the second or third within this age group really points to kind of how high risk this age group is. The other thing I want to point out is we have tons and tons of funding, tons of research for lots of different diseases. But death by suicide in this age group in particular is actually more common than from cancer, heart disease, AIDS, birth defects, stroke, pneumonia, influenza, and lung disease combined. So you'll see on this graphic on the right, some of these other causes of death, they've actually gone down over recent years. There's been a little bit tick up, but suicide's been going up. This is across age ranges, but when we think about high schoolers in particular, the 2021 CDC survey actually showed that about 22% of US high school students reported having seriously considered suicide and 10% attempted suicide. This is a quarter of our high schoolers, right? So this isn't just a small number of kids. And when we think about how many attempted, that's 1 in 10. This is a very, very large number of high school students. We don't have concrete data yet from 2022, but provisional data from the CDC shows that 2022, it's likely to have the highest recorded rates of death by suicide. There's a lot of factors that influence this. We know COVID had a really big uptick in mental health problems, especially suicide among youth, being pulled from schools, not being able to get those social supports from peers. That said, we're kind of not totally back to normal, but in a lot of ways back to normal. And we still have this kind of increasing trend with seeing lots and lots of youth in the emergency departments for suicide. If we look at this graphic on the bottom here, so suicide rates have been increasing for the past 20 years, really. There have been some trends of it going down within that 20-year span, so it's not all bad. But if we look at this kind of big, bold blue at the bottom, we see that there's actually been a 57% increase in suicide rates among 10 to 24-year-olds between 1999 and 2019. So if we look at the overall trend, there's been an increase in this behavior. Now, I also want to point out that we see in this graphic, looking at different racial and ethnic groups, that around age 10 to 14, across the span, we see this major rise in suicide rates. So across racial and ethnic groups, we see an increased risk at 10 to 14 that continues to increase to 15 to 19 and really doesn't drop off until 20 to 24. And this matches onto some of the things we just talked about with this increased heightened risk in this 10 to 24 group with the second to third leading cause of death. Just to expand on this a little bit, I don't know how well you can see this graphic, but this breaks it down across a couple different demographic factors. So what we see here is that across race and ethnicity, what we historically know is that white males are historically the most likely to die by suicide. That said, if we look at just race and ethnicity, that American Indian and Alaskan Native actually have the highest rates of suicide, and that they also have the highest increase in percent change from 2011 to 2021. Other groups that have been showing particular risk over recent years are Black, Hispanic, and Asian Pacific Islander. There's also been increases in the percent change of suicide death rates among white individuals as well. But what's really alarming is these rates over 50% increases that we want to pay attention to, leading to kind of just different groups that we want to pay attention to, changes in how we want to screen, but also just noting that across different areas, different people, different races, different ethnicities, different ages, that we really want to be paying attention to suicide risk across the gamut. You'll note in the age group, you'll see the 12 to 17 range actually has the lowest rate of death by suicide. That said, it has the highest percent change over the last 10 years. So it's been really, really increasing, which is why we want to pay attention to this age range. And then you also see, we already talked about differences in males and females. So males are more likely to die by suicide, but they're less likely to attempt. The major difference here is methods that they use to attempt suicide, with the major difference being males more likely to use firearms, which are more deadly. And then the last thing I want to draw your attention to is the bottom, rurality. We see higher rates of suicide in non-metro and more rural areas. And we think this has a lot to do with just lack of access to care. So right now, there's a big gap in care for mental health across different regions, different geographic settings. But in rural settings, there's even less access to services. Telehealth has helped a little bit, but when we think about crisis services, inpatient services, there's a really big gap in what services are available, especially for youth. So this is all to say suicide is a major public health crisis. This age range is a group that's particularly at risk. And the semi-good news is that in a survey, 94% of adults did report that they believe suicide is preventable. The question becomes, how is it preventable? What can we do to actually prevent it? One area is targeting different healthcare settings, regardless of if there's mental health specialties within those healthcare settings. And that's because we see that 92% of people who die by suicide had a healthcare contact within the last year. And the last year can be a pretty big range, right? But over 50% and over 50% of youth who die by suicide had a healthcare contact within the last month. And a lot of the time that's primary care. And this has led to national guidelines that recommend that all medical settings and not just mental health specialty settings start screening for suicide risk. And I know this is an extra thing for people to do, but it is an extra way to kind of reduce risk, to identify people in need, and to start this stepped care pathway that we need to be talking about. And we'll talk about what that looks like in a little bit too. The other piece of this is we're seeing a lot of kids showing up to emergency departments with suicide, either after an attempt or with suicidal ideation, and it could be the first time that they're presenting with any mental health concerns. In a lot of ways, that's good. The ED is meant to kind of give crisis intervention to do a suicide assessment. That said, right now, EDs are overburdened. They're getting more kids than ever with mental health referrals to the ED, and most of these kids are being sent back, often to their primary care doctors or other outpatient medical specialists that they already have established relationships with, which means the burden of these services is coming back to primary care and outpatient medical settings, who might not already have those systems in place to manage mental health and to manage suicide. So that means that we need to figure out ways for different medical settings to proactively manage suicide risk. And one of the major ways to do this is to be implementing suicide screening universally with active follow-up. And that can look very different for different settings, depending on what resources you have in your own settings. In order to do this, this also means that we need increased training. That's part of what we're doing today. And then also just having this responsibility and people understanding this responsibility to develop these processes within different medical settings to identify, manage, and treat suicide risk. That's not to say that we don't never want to refer to specialty mental health care. We definitely do, but doing what we can in different settings. And we're talking about healthcare, but also within schools and other systems as well, to be able to identify when risk is present. All right, so what does this look like? What is the role of healthcare providers in different settings to reduce suicide? And what we're going to be focusing mostly on today is these non-specialty settings, primary care, outpatient medical, and even when you're in a hospital setting without mental health. So since 2011, there's been a focus on integrating pathways of suicide care. Pathways of suicide care in outpatient medical settings run the gamut from risk detection, where we talk about screening and then assessment, shared decision-making across medical professionals, short-term risk management, which might look like a 1 or 2 time crisis intervention, referral to treatment when needed and appropriate, long-term surveillance, so really highlighting the need to follow up, not just doing a one-time intervention and then hoping that kid gets referred somewhere else, and then following up long-term. And this brings us to why we want to do this. This obviously leads to a lot of extra work on outpatient professionals, especially folks who didn't get into mental health as their specialty. That said, we really want to reduce referrals to the ED and inpatient mental health when it's appropriate. Not to say we never want to do it, but we want to know when we can help kids in an outpatient setting, because what we've found is that the best care available is often in an outpatient setting when it's the least restrictive environment. Least restrictive environment meaning least restrictive environment needed to keep that kid safe and give them the necessary support and intervention that they need. And why do we want to do this? Well, one big reason is that inpatient care is really expensive. It's expensive for youth, it's expensive for families, it's expensive for healthcare systems. But in addition to that, inpatient services takes kids out of their normal day-to-day setting. It removes them from their social support, from their peers, from their family, from other systems like school. And that's not necessarily all bad. Sometimes we hear kids say they need a break, right? But inpatient services is really meant as crisis stabilization. The goal of inpatient is to be a short-term crisis stabilization service with the goal of sending kids home when they're safe. So if we can keep kids safe at home, that would really be the goal. This is typically better for youth mental health. It reduces some risk factors, it reduces stigma, and it increases access. And so this is our stepped care model. This is from the Zero Suicide Pathway. This idea of stepping care up from the least restrictive environment, starting with outpatient, least restrictive care, and stepping up as needed to match youth where they're at, where they need services. When we think about this, our first step in a stepped care pathway is crisis centers or hotline supports. This could be 988 local crisis hotlines, different text numbers, and referring them to those, providing those different crisis services, those different numbers, and then following up with them. Again, highlighting that we need to follow up with youth. We can't just give them a sheet of paper that says contact these people. After that, if that's not enough, and oftentimes it's not, conducting a brief intervention. Sometimes that's just a one-session intervention. Sometimes it goes up to 4, 5, 6. And again, following up, linking kids to care when it's needed. So at each of these different steps, assessing, was this enough? Do they need more? Do they need additional support? Are they safe? And determining from there if we need to keep stepping them up. After that, we have outpatient care. Outpatient care we typically think of as outpatient specialty mental health, but that doesn't mean it can't be occurring in other settings. We can also be thinking about integrated behavioral health within primary care. It can be primary care clinicians or other medical professionals providing these briefer interventions and follow-up. But a lot of the times this is where we're thinking about outpatient specialty health or specialty mental health. Following this, we have emergency respite care. Those could be those, a crisis care service, something within a hospital setting, somewhere to be able to monitor for a little bit longer. After that, we have inpatient or partial hospitalization and intensive outpatient settings. These can be really useful services, and I also want to highlight that a lot of them have long waits. So in order, if you are making a referral to one of these programs, oftentimes it does mean bridging that care with outpatient care or a brief intervention. And then all the way at the top, we have our inpatient psychiatric hospitalization. So I again want to just highlight, we're not saying we don't want to refer kids to inpatient, that we don't want to send them to the ED, but instead that we want to understand when that level of care is needed and how it's going to be helpful, because it's not always going to be helpful for a kid with low suicide risk. This means coming up with different ways to actually implement suicide prevention and these suicide prevention pathways in outpatient settings. And this looks like a lot of different factors, but there's a couple pieces I want to point out. And the first is that elements to suicide-specific care in outpatient settings or other hospital settings requires two different pieces. The first is creating a protective environment. That means within your healthcare system itself, as well as within the family system or wherever that youth is living. And the other is by strengthening access to and delivery of suicide-specific care, which in part happens just by delivering these services within outpatient settings and non-mental health settings. Now that's easier said than done. So to strengthen access, the first step of that means universal screening, knowing when to screen, who to screen, how to screen, and we'll talk about that in a moment. That also means ongoing monitoring of suicide risk. If you have a kid flagged as suicidal or having some level of suicide risk, having a plan of how and when to follow up and how within your clinic that's going to be possible and feasible. Being willing to treat those suicidal thoughts and behaviors directly is another key aspect of suicide prevention within outpatient settings. Now, again, we're not talking about the kid with acute risk who already made an attempt. Those kids are probably going to the ED, especially if they need medical attention. But the kids that are having passive suicidal thoughts, maybe moderate suicide risk, where they're talking about they have a method, but somebody can keep them safe. These are kids that can be treated in outpatient settings. Learning how to anticipate future crises, and we'll talk about creating a risk formulation in a moment as well. Being able to understand what is more likely to make a crisis escalate and having safety plans in place and triage strategies. And then the two bottom pieces within this access piece I want to really highlight is being willing to seek consultation. There's different consultation lines, there's different people within clinics. Even without mental health specialists within a clinic, having people to seek consultation with, even if it's just a gut check, can be really helpful and can make people more willing to provide these services. And then the last is providing care coordination. This currently is a major limitation in a lot of what we do. We know that there's not enough mental health professionals. We know that there's more kids who need services than there are mental health professionals. So finding ways to kind of increase care coordination, build relationships across different settings, even if it's telehealth, even if it's care consultation, can be really helpful to improving access. Now, the other big bucket here is this creating protective environments. So the first step of that is being willing to ask about suicide and ask about suicide directly. Asking about suicide directly is going to make people more likely and more willing to talk about it. But the other piece is involving caregivers, the suicide assessment and intervention. especially for kids. We know that caregivers are a really pivotal role in being able to protect youth, but they're also really important in some of our main interventions that we're going to talk about. So lethal means restriction, having parents and caregivers buy into that, understand why we're having them do it, and then actually implementing it at home and coming to you or coming to another provider to problem solve any issues that come up are going to make a huge difference in restricting access. Caregivers also bring youth to appointments. So even if you have that 13 to 17-year-old who in the mental health world can consent to treatment on their own, having a parent is usually really helpful because those kids are not going to typically want to call and make their own appointments with the mental health provider. Having a parent, having a caregiver, or a trusted adult be willing to provide support and help bring them to appointments, as well as provide that lethal means restriction and help them use their coping and problem solving skills is going to be really important. The last thing I want to highlight with caregivers in particular is that family systems can be a risk or a protective factor for youth. Having a strong, connected family system, having parents ask about how they're doing, having parents ask about safety, do positive one-on-one time with them, do positive things together, can reduce risk. It makes youth more likely to talk to parents. It makes youth more likely to engage with them. And this is a positive social support. Having parents who say, you know, there's nothing to worry about, ignoring them, not validating their concerns can cause a risk factor. So we really want parents involved as much as possible within our interventions. Now, we know that there's different levels of risk, right? So for a kid who's not reporting high risk, they might not want their parent involved or a caregiver involved, and that is their right to choose not to have their caregiver involved if they are low risk and they're not reporting any intent at the moment. That said, trying to encourage them to have caregivers participate, especially in outpatient settings and primary care in particular, is really, really important. So trying to get their buy-in and help them understand that it's not about trust, it's about being able to keep themselves safe. Okay, so we're going to jump a little bit into how you actually do these. And some of these might be familiar. There's lots of different screening tools, but as I mentioned, universal screening is this first really big step in being able to prevent suicide. So the American Academy of Pediatrics recommends universal suicide screening for all youth ages 12 and over. Now, this is a little bit different than the National Institute of Mental Health, which actually recommends ages 10 and over have universal screening. That said, this isn't totally contraindicated, right? So we have the American Academy of Pediatrics, which actually does say they do want youth ages 8 to 11 to be screened for suicide when it's clinically indicated. And this can be when they flag on the PHQ-9, that depression screener, item 9 that asks about suicide. It might be when they come in talking about suicide or just bring up any other warning signs or indicators. Now, in contrast to that, we don't have any guidance right now on asking about suicide or screening for suicide for youth under age 8. That said, if somebody does indicate risk, indicates a major warning sign, we do still want to ask about it. So recapping that, overall, universal screening is recommended for ages 12 plus. Different frameworks from National Institute of Mental Health and the Zero Suicide Framework would recommend over age 10, and that's in large part because of the number of kids coming in younger and younger, usually like 8 to 12-year-olds at this point. But it can be clinic dependent and based on your own context. So that's who to ask and when to ask, but how do you ask? So how you ask is just as important in suicide prevention as knowing when and who to ask. So the first part is looking for signs. You want to look for those risk factors, but you also want to look for protective factors. Just looking at risk is going to ignore all of those protective factors that might reduce the level of risk that that person has and might allow them to be seen in an outpatient environment. The other piece is asking in an empathic way and actively listening to what youth have to say, as well as caregivers. Showing that you're actively listening, that you care what they're saying, that you're taking them seriously is going to increase their willingness to talk to you, increase their willingness to engage in mental health services broadly, and is going to just lead to a better experience with the mental health world, making them more likely to have treatment in the future. This next part, asking directly about suicide, is really important, but can be really uncomfortable, especially when working with kids. But asking directly about suicide is a really key way to make sure that people are talking about it. People are more likely to endorse suicide risk if you ask directly, rather than if you say something like, have you ever had thoughts of maybe wanting to hurt yourself? That might be more comfortable, especially with a 10-year-old, right? But asking instead the question, have you ever thought about suicide? Are you having thoughts of wanting to kill yourself? Are you having thoughts of wanting to be dead? Those direct questions are going to be more effective and are more likely to get a person to respond honestly. If that person does endorse suicide risk, that leads us to our next two steps, which are removing the dangers or lethal means restriction, and we'll talk about that a little bit more in depth, as well as coming up with that risk formulation to figure out what are your next steps. What is your dispo plan? All right, so how do we screen? What are the common screeners? There's three big ones that have been used that have a lot of validation, especially for kids. We have the Ask Suicide Screening Questionnaires, or the ASQ. This is the shortest and briefest of the ones we talk about. A lot of times the ASQ will be combined with the Brief Suicide Safety Assessment, or the BSSA, or the Columbia Suicide Severity Rating Scale. Now, the ASQ is nice because it's super short. It's 4 to 5 questions. And if somebody says no to everything on it, it takes about 30 seconds. A lot of clinicians right now are still using the PHQ-9 because we know that's used for depression. That said, it is a depression screener. It's actually not validated to assess suicide risk. So one easy way to add a suicide screener on top of the PHQ-9 that some clinics do would be adding this ASQ, these 4 or 5 questions, to the bottom of the PHQ-9. And you can even Google that online. There's an NIMH toolbox that has examples of that screener with both of them there together. Now, like I said, if the ASQ is negative, it's very, very short. If there is risk that's indicated, one example of next steps that the NIMH uses would be going into this BSSA, or the Brief Suicide Safety Assessment. So the ASQ is a screener. It's brief. It's just meant to assess yes or no is there risk. After that, you really want to get a more in-depth assessment to understand what are the risk factors, what are the protective factors, what is the level of risk. The BSSA helps to do that. It's a little bit briefer. The alternative is the Columbia Suicide Severity Rating Scale. This one is a little bit longer. It's more in-depth, but what's nice about it is it has some triage guidelines outlined at the end to help providers make decisions on what level of risk there are and what to do. The other nice things with these are validated for kids. So the ASQ is validated for use with kids as young as 8 years old, and the CSSRS is validated for 12 and up, but has been used with kids as young as 6 years old. There's different versions of it. So there's a brief CSSRS, there's a longer CSSRS, and it can be integrated into electronic health record systems as well. All right, so you complete the ASQ, that's your brief screener. Somebody endorses risk. From that, you're going to then use your follow-up screener, the CSSRS or BSSA most commonly, and that's going to help you formulate your risk. And we're going to talk about what a risk formulation looks like in a second. From that, you're going to determine your next steps. The most common interventions that can be implemented easily in different healthcare settings without a mental health professional would be safety planning, lethal means restriction, and then figuring out any other dispo planning. Does that kid need to go to a higher level of care? And so we're going to pay attention to all 3 of those things. So this is a risk formulation. So when we're coming up with our risk formulation from those assessments and screeners that we just did, we want to look for the dynamic risk factors and the more enduring risk and protective factors. More enduring ones are strengths and protective factors, long-term risk factors, so anything that's been going on longer than the last 6 months. Considering impulsivity or self-control, including substance abuse. Really, use of substances can be a major risk factor. It increases impulsivity. So anyone using substances we look at as a more enduring risk factor. And then any past suicidal behaviors. We know that somebody who has attempted suicide in the past is more likely to attempt suicide again. So we look at that as an enduring risk factor. More dynamic risk factors we want to consider are any recent or present suicidal ideation or behaviors, as well as non-suicidal self-injury. Any stressors or precipitants that might be recent, we can think of that as like a breakup with a significant other. Any symptoms, other mental health or medical diagnoses or recent changes in their life, and what their engagement and therapeutic alliances with current providers. So those are all more dynamic risk factors that help us figure out this risk formulation. Now within this circle on your right, I want you to pay attention to these 4 different areas. So there's the risk state, risk status, and then available resources and foreseeable changes. The risk status is somebody's risk relative to others in that population. So if we're thinking of primary care and we have a 15-year-old girl come in reporting chronic suicidality, we want to think, is that happening in all of our 15-year-old girls coming in, or does this seem more high risk than those other 15-year-old girls coming in? And that risk status is going to give you an idea of how high risk that person is. Now combine that with that person's risk state. Risk state is how high risk is that person relative to themselves a year ago or at their last visit or their typical state. So if that 15-year-old girl came in a year ago and there was no depression, no suicidality, nothing reported, and now they're more high risk than they were a year ago. So you're going to compare this risk status and risk state and use those together. And then in addition to that, think about what is that person's available resources and what foreseeable changes might be going on in their life. Available resources that we really want to pay attention to are internal and social strengths, as well as social support for safety planning and lethal means restriction. A lot of the times we're thinking about this as the family system, their caregivers, peer networks, school networks, what are they involved in, any other social clubs that they're in, church, anything like that. Foreseeable changes that we look out for are any changes that could quickly increase risk. For teens in particular, we think about things with school, we think about things with peer and romantic relationships, and we think about things with parents. This could be a parent divorce. This could be knowing they're going to fail this year and have to repeat a grade. It could be failing a major test or not getting into the college they want. It could be a breakup with a significant other, but also a lot of times this is a really high emotion group. So we also want to think about relationships with friends are really important. So we don't want to discount somebody coming in and saying that, you know, them and their best friend are in a fight and are no longer going to be friends. That can still be an important risk factor. So altogether, you're going to look at this risk status, risk state, and then together the available resources and foreseeable changes to determine what is that person's risk formulation. The available resources here are key. A person that does have caregivers or trusted adults who are willing and able to provide safety supervision at home, to restrict lethal means, to help connect them to care, is going to be a lower risk individual than somebody who doesn't have the trusted adult that's able to provide that supervision and care at home. Okay, so that's your assessment. So next steps, you have your risk formulation. What can you actually do? So there's a couple different interventions and considerations that you can do in different outpatient medical settings to decrease risk. The first is counseling on access to lethal means, and the other is crisis prevention or safety planning. And we're going to talk a little bit more about those more in depth, but I also want to bring your attention to these bottom three pieces. The assessment you do and that risk formulation you come up with is going to help you understand what frequency or level of care is needed, right? So if you have a kid that's really high risk and they have medical acuity of any kind, you're going to send them to the emergency department. You're not going to try to treat that kid in an outpatient setting. But with a lower risk kid, you might determine this kid needs to be seen once a week. They need to be seen once a month. I need to see them once and then just follow up and see how they're doing. And that leads to how much monitoring or supervision do they need, both by you as a healthcare professional as well as their caregivers. And this can be a collaborative assessment that you can do with other providers and their trusted adults to figure out how much supervision can be done at home and what is a comfortable rate of checking in on them. And then this last piece is just seeking consultation. We know this is hard. We know even if you are a mental health professional, this is hard. So checking in with others, do a gut check, see how it feels, see if this feels like the right move and what other providers might be doing as well. Okay, so in terms of the actual interventions themselves, I'm going to talk about reducing access to lethal means, and then I'm going to talk about the safety planning intervention. So starting with reducing access to lethal means, the reason we do this is because the interval between somebody thinking about suicide and then actually taking action on that suicidal urge can just be a matter of minutes. A lot of times these are really impulsive behaviors. They're not always impulsive behaviors, but a lot of times they are. And especially for teenagers who are more impulsive in general, a lot of suicide attempts happen within 30 minutes of them initially thinking about wanting to kill themselves. So the idea of lethal means restriction is really just to buy time, to create space between having that suicidal thought and being able to act on it. If we know that there's things that they have thought about to use as a means to kill themselves, we want to get rid of those things. We want to approach lethal means restriction as a collaborative process with parents and caregivers in particular. And again, this is a key area that we really want caregiver buy-in. In particular, the one area that always needs to be discussed within lethal means restriction is restricting access to firearms. So always asking caregivers, are there firearms in the home, is a really important question within restricting access to lethal means. But the other pieces within this is asking youth as part of that assessment, what are the different things that you've considered using to kill yourself or harm yourself? So we want to think about non-suicidal self-injury here as well. A lot of the things that typically come up are medications and sharps, so knives and razors. So the main things we always want to restrict, always firearms. And the recommendation is always to remove them from the home. And if that's not possible for any reason, locking up the gun and the ammunition separately in separate lock boxes that the child does not have access to. And if possible, without them knowing that they're in the home. But really the recommendation is to fully remove them from the home. And then medications, the recommendation is to coach parents to lock up medications. And even if the youth needs medications on a daily basis, to be administering those medications one at a time each day, rather than having the kid have access to their own medication. And then sharps, again, assessing, is this something that the kid has indicated that they've thought of using? Are they self-harming? And figuring out what that might look like. A lot of kids will come back and say, well, I need my razor to shave. And so a lot of parents might do something like a checkout system where they're holding all of the sharps and the kid can check out a razor for a shower and bring it back to the parent, something like that. But the really important point I want to highlight here is that lethal means is going to look different for different people. And the really important piece is always asking about firearms and then seeing what other means that that child or individual has considered using, and then figuring out ways to lock those up and remove them. Now, lethal means restriction and training can be a lot more in depth than this 2-minute kind of info I just gave you. These are two resources on the right. The Counseling on Access to Lethal Means has a free online course. I'll have my email at the end of this as well, and I'm happy to talk to anyone or send those resources as well. And then the Firearms Culture and Suicide Care. These are both online resources. They are free training materials. It's a free training video to help clinicians from different settings be able to implement lethal means restriction. The last thing I want to highlight here is that you will probably get caregivers who either don't know or don't know how they will lock something up, don't think it's feasible, or might even be unwilling to kind of not have their gun on them. We really want to talk about this in a collaborative way with parents, provide the psychoeducation again, that this is a short-term solution, that we're trying to get through a crisis episode, and that the idea is to kind of prepare for youth to be able to not be able to act on those thoughts when they're occurring, to buy time. A lot of times that psychoeducation will be effective and work. Other times, some of the extra handouts and different resources on these different links are really helpful, as well as handouts for people, as well as problem solving. What can you do with a firearm in order to get it out of your house if you need? Okay, the other thing I'm going to talk about is safety planning. A lot of people have heard of safety planning. What I want to highlight here is that safety planning is an intervention. Safety planning is not actually meant to just be a piece of paper that you hand somebody to fill out. The graphic we have on the right over here is the Stanley Brown safety plan. This is the one most people have heard of the different versions of them. And there are a lot of different versions of safety plans, but regardless of the type or template you're using, the main goals of it is to get a comprehensive list of warning signs and triggers for a crisis or suicidal episode, determine coping strategies, as well as resources to use during a suicidal crisis. And the other thing to highlight here is just that the safety planning intervention is not for use with every single person who walks into your office with any level of suicide risk. That kid coming in who says, I just wish I could go to sleep and not wake up, probably isn't your target for using a suicide safety planning intervention. And the reason for that is that the research for safety planning interventions is that it's most effective for people at increased risk of suicide who are not requiring immediate rescue, meaning that there's not medical lethality at that moment, and for use with more high risk or moderate to high risk individuals. So people who have a history of suicidal behaviors, including suicide attempts, interrupted attempts by self or others, so those interrupted or aborted attempts, and people who have made preparations or plans for suicide, who have a recent history of suicidal ideation, who are otherwise determined to be at risk for suicide, and again, can be used across the age range. So it can be used with children, adolescents, and adults, with just highlighting that for children and adolescents, you're going to want to include caregivers in the safety planning intervention. But again, the big point to highlight here is that the safety or crisis prevention plan should be used with any patient that has active current ideation or a suicide attempt within the past year, rather than that kid coming in with that fleeting thought of, I just kind of wish I didn't have to wake up. And why do we do this? It can be a lot of work, but it's designed to manage acute suicide risk with the idea of when people are in a suicidal crisis, so at the top of that risk curve over there, people are more likely to not be able to pull from the coping skills or problem-solving skills that they have available to them. It's harder to think in that moment. So the idea of a safety plan is to come up with a list of skills, strategies, and people to contact and access before we get all the way up to this crisis, to be able to either divert and not get to the crisis, or to be able to have skills and people that will be able to keep somebody safe through that crisis. So the idea of safety planning is truly to be able to cope ahead and come up with a concrete plan to be able to stay safe before that crisis happens. And the intervention itself includes a couple different tasks, including identifying and assessing suicide risk, obtaining a crisis narrative, providing psychoeducation and introducing the safety plan, identifying warning signs, explaining how to use it and completing it, implementing it, and then following it up. So again, following up everything, following it up, problem solving, what didn't work, what did work, and troubleshooting so that it's more effective moving forward. Now I'm going to focus on the crisis narrative for a second, just because this is the piece that's often overlooked. I again want to highlight this is an intervention, right? Not just a piece of paper to give. And this crisis narrative is a conversation that you can have with that individual and or their caregiver, focusing on the specific suicidal crisis that led them to your office that day, less so on historical vulnerabilities, so not on their past suicide history. And it provides an opportunity to build rapport and provide important validation for people, as well as to let them tell their story. But more importantly, it also helps them identify triggers. What led up to this suicidal ideation or attempt? What are some of their own warning signs that they can notice or others can notice to help recognize when they need to use coping skills or reach out for support? And it also helps them visualize that risk curve, that idea that pain goes all the way up, but it also comes back down. This idea of having that thought that you want to act on that suicidal urge isn't going to last forever. And if we can help them get past that tip of the arc, that it'll come back down again. And this allows an opportunity to cope. So this is what we want them to be able to do in order to cope with those suicidal urges to reduce that need. Paired with our narrative, we want to provide that psychoeducation, exactly what we just walked through. So providing that risk arc. This is from Brown, Stanley, and Green. But the idea of providing education on this risk arc, that the crisis plan or the safety plan is really meant to get them through those periods, similar to lethal means restriction. It's not meant as a long-term solution necessarily, but it is that crisis intervention that will help build space between having that suicidal urge and acting on it, as well as help give caregivers things that they can do to support, and having youth be able to kind of bring their risk back down if they get a little bit up that arc, but not all the way to the top. We talked about the different components of the safety plan, but just to reiterate, we have our crisis narrative, providing psychoeducation. And then regardless of the different templates that are used, the key pieces within the safety plan itself are identifying the triggers and warning signs, recognizing what's needed to make the environment safe. So that's part of our lethal means restriction. Discussion of what warning signs look like, what are the thoughts, feelings, and behaviors that an individual might notice, but also what others might notice so that others might be able to prompt them, especially kids, when it's time to use coping skills. Recognizing coping skills an individual can use on their own independently, as well as other people and settings they can use to distract themselves in order to reduce their risk before they get to a crisis. And then lastly, being able to recognize crisis resources and trusted adults they are willing to reach out to in the event they do get to a crisis. And along with who those people are, recognizing what they want those people to do. And that's really important. We'll find that most people, and teens in particular, do not want somebody asking 50 questions when they're in a crisis. Really what we often recommend is having caregivers not ask questions and probably not speak too much unless the kid wants to talk or asks them to. And instead just providing safety supervision. This might mean sitting next to them and watching a TV show. It might mean keeping their door open and checking on them. A lot of times it means giving them a hug or offering them a cup of tea, something like that, until they come back down. That done? Okay. All right, and we just have gaps and solutions. So these are just some of our current gaps. We have a lot of underreporting and stigma still, some limited training, lack of continuity of care, and breakdowns in communication, especially across different systems. And the big one we think about is just between primary care and emergency departments in particular, having different systems and levels of acuity that we think about, with potential solutions being enhanced training, so something like this, but also within different systems, different screening protocols, and finding different ways to implement those screening protocols and different practices consistently as part of a stepped care model when possible, and integrating mental health in some capacity, whether that's through care coordination, integrated within the setting, or as part of kind of calls and check-ins. promoting crisis helplines when it's appropriate, and then collaborating across different agencies. And there's different techniques to use this. The National Institute of Mental Health has a lot of online resources to help settings such as primary care reach out to other specialty mental health agencies to build referral networks. Okay, and I'll skip my summary because I'm over time. Thank you.
All right. So thank you, Dr. Danzo. Very much appreciate your presentation. It's a Q&A right now. If anybody has questions, we just ask that you have a mic because the people that are on virtual can only hear if you have a mic. So if you have a question, go ahead and raise your hand and the volunteers will bring you the mic.
In that initial visit, like the crisis prevention, are you like advising starting medication? So, or is it showing any like help if you have an actively suicidal, probably depressed, starting like an SSRI?
So I will first start with saying I'm a psychologist and not a psychiatrist, so I don't work with medication, so can't answer that as effectively. But I think it would really just depend on the presenting problem and how, like, if this is something that's been long-standing and if they've had depression and, you know, other mental health concerns, and considering if then a medication might be warranted, versus if it's a, you know, the first time they're showing any mental health concerns at all and it's showing up a suicide risk. I think typically we'd want to just figure out what else is going on, what's causing it, and then determining that. But again, I'm a psychologist and not a psychiatrist, so I don't work with meds as much and can't advise on that.
This question actually, I'll set the stage for it.
Okay.
Because skin, brain, and every nerve in the body is made from the same tissue.
Mm-hmm.
The incidence of skin problems and nerve problems also parallel the problems with central nervous system.
Okay.
In terms of the triggers for suicide,
Mm-hmm.
do you find that other systems then feed into this, such as itch is intolerable. We cannot tolerate itch. It must be eliminated. So people will scratch till they're bloody and then state it feels so good.
Mm-hmm.
There's damage there, but there's also the central nervous system aspect of this. Do you find in the suicide issues that there are other systems that are feeding into this?
Yeah, I think that's a great question. I think it really depends on the individual. What we do know is that people with chronic illnesses are likely to consider suicide at some point. And that again is very person dependent. So that's an overgeneralization. But we will see people with a chronic illness who they know it's not going to get better, especially if it feels really intolerable to them. Intolerable being that key word that you brought up. Someone who has something going on in their life that feels intolerable and is in an environment that feels conducive to being able to manage that is probably going to be more likely to consider it at some point. But again, ideation has a huge range, right? So having that thought of, you know, I really just don't want to deal with this anymore. And wouldn't it be easier if I wasn't alive to deal with it, is different than having that thought of, this is so intolerable that I can't manage it and therefore I want to kill myself. So I think that's not a straightforward answer to your question. But I think, you know, that would be part of our risk formulation, that risk factor, and especially if it's an enduring risk factor, is something we want to take account.
Okay, thank you. I just had some questions about the logistics of how to do a screening questionnaire. I know there are better ways to do it than we're probably doing. I mean, is that, how important is that? And are there any easy ways to get that done?
So just to clarify, is the question how to feasibly screen?
Yeah, how to administer the screening questionnaire. I believe ideally you want to have your patient answer it without their mother helping them and looking over their shoulder. But, you know, in its time frame where we're very limited, it's really difficult to do that. So I think it usually gets done with the mother hovering and helping the child answer the questions, or just being present for the child's responses to the questions, which I know is not ideal.
Yeah, I think ideally it would be without a parent hovering over their shoulder. That said, you know, you might have an 8-year-old that discloses something, and then it's probably appropriate for a parent to be there. But I think a way to do that might be, you know, if the parent is there, just asking them to leave for a couple minutes, the way you might in other parts of a well child visit, and just asking a follow-up and asking very directly again, you know, like, hey, you know, I already saw you answered these, but just wanted to double check. Are you having any thoughts of wanting to hurt yourself or kill yourself? And just kind of double checking it on it like that. But again, I know all clinics are different, policies are different, and it is hard to do that in different settings. And asking with a parent there is still better than not asking at all. But it might be finding ways to provide, you know, handouts to them, or finding a way to just have a parent go to the other side or wait in the waiting room, and just making that part of the policy. Again, adding the ASQ in particular to something like the PHQ-9 is very, very brief. It doesn't take very long, and that could be a good indicator too of whether to even allow the parent into the visit. If you feel like you do need to ask more follow-up questions, because again, it takes 30 seconds if they say no to everything. But again, it does depend on what that looks like within your clinic already.
Hi, I'm with Good Shepherd in Hermiston, and we're a Legacy Hospital and on Epic. And I don't know if anyone else here is on Legacy Epic, but previous place I worked, if you had, they would do a PHQ-2, and if it was a positive, it automatically EMR dropped down into the PHQ-9. So it kind of gave you that. I wondered if here this ASQ drops onto anything. And when I saw ASQ up there, that rang a bell for me, as we do the ages and stages questionnaire called the ASQ.
Yes,
so if you Google
different than
ASQ, that's automatically on all of our younger ones. So I'm not even sure if ASQ comes forth in Epic. So I think for a lot of us, the alphabet soup gets intimidating.
Mhm.
That's one point.
Yeah.
And so if anyone can answer the Epic question, that'd be great. Number two, just a commentary. As of July 1st in Oregon, we have a rule for chaperoning with a sensitive exam. And I think it's not just to protect patients from predatory physicians, but it's to protect physicians from patients that misread. Yeah, for example, I had a complaint after I did a breast exam on a 16-year-old who wanted her mom out of the room. Then the mom heard I touched the daughter's breast and complained to the hospital. So now we have to have yet another person in the room. So it does get very awkward, especially if you're in a high volume situation, to have time alone with the patient, but then you now need a chaperone in the room. So often you end up with the parent in the room. And I don't expect anybody's got a solution to the problem, but it definitely does complicate.
Yeah, that
picture.
sounds like it definitely would complicate. I would say for first, alphabet soup, definitely intimidating, and I definitely played into that by using lots of different acronyms. There is the ages and stages questionnaire for younger kids, and then the one we were talking about is the Ask Suicide questionnaire. And if you Google NIMH with that, it'll show up. But I think adding it into an electronic health record when possible is really helpful, because it can just drop down like that. Not everybody uses the same electronic health system. And I will say, you know, working with Epic, it could take longer or shorter to get it added into it, depending on what your system looks like. With parents chaperoning, I think probably then the answer is finding creative ways to see if you can hand them that screener and see if they'll do it without a parent looking over their shoulder, and maybe just encouraging parents to give them space, knowing that parents aren't going to always do that at time. I mean, I think we have to be realistic and know that lots of parents are going to still look over their shoulder, but trying to encourage them, and even providing just some psycho ed of, you know, if you hover, they might not answer as honestly, and we want to make sure that we're giving them the best care we can, which requires them to answer honestly. Not a great answer, but you're right. We're dealing with realistic systems that we have in place.
All right. I think that's the time we have for questions. So thank you, Dr. Danzo.
Thank you.
There's your email there. Is it okay if
Yeah.
everybody can, if they have a question, they can contact you?
Yep. Feel free to contact me with any questions, and I'll add my email to the app as well.
Perfect. Thank you so much.